Hi, this is Brian Kim. I'm going to share with you this case of a patient who I did a Yamane intrascleral haptic fixation technique. And once I pushed the haptics down into the sclera, I noticed that it was decentered. And so for those of you who have experience with this technique, you might know that it's not that easy to pull up the haptic once you embed the flange into the sclera. And so I'm going to show you an easy way to be able to pull up the flange for repositioning. In this case, all I had to do was trim the haptic on one side. There are situations where you actually have to pull the haptic all the way through the sclera back into the vitreous space and reposition completely. But for the purposes of this video, this is simply a pulling up and then trimming the haptic. And for the specific purposes of this video, I'm going to be bypassing and skipping the vitrectomy part as well as the IOL explantation part and going straight to the Yamane. You can see I'm using a wet cell sponge to dry the conjunctiva, and then I'm using the tip of a cannula that's been marked, and I'm marking the limbus and then marking 180 degrees apart using the axis ring to help me. I thought I was a little bit decentered, so I had to mark again on the left side. I'm using a caliper that's marked 2.5 millimeters posterior to the limbus on each side now. Again, I'm using the cannula that's been marked with ink in order to get a nice round mark. And then I'm marking 2 millimeters adjacent. On the left side, it's a backward 7, and on the right side, it's a backward L. I'm bending my needles now here. I'm doing the trailing haptic first technique. So the right side needle is going to be bent about 9 millimeters from the tip, 70 degrees, and on the left side it's going to be bent at the hub about 70 degrees, and the angle of the bend is going to be such a way that the bevel of the needle is going to be facing the approach of the haptic. So again, for the trailing haptic first modification, the lens will be injected and the leading haptic will be externalized through a contralateral limbal incision. The surgical assistant is helping me to deliver the lens, and with my left hand, I'm going to pull the leading haptic out through the contralateral incision, and I'm holding the barrel of the injector with my right hand. Once the haptic is delivered out of the eye, I'm able to focus my attention and make sure that the optic comes out planar in the correct configuration. This will help keep the leading haptic facing to the left. And once the optic is completely delivered, I'm able to sweep or make sure that the trailing haptic is on the right side to maintain that correct optic configuration. Once the lens has been delivered, dispersive viscoelastic is injected to coat the corneal endothelium and to push the optic back. And then microforceps are used to grasp the trailing haptic in such a way that it's captured within the incision in a U-shaped configuration. Correct placement of the needle through the sclera really depends upon correct orientation and position of the conjunctival marks. The conjunctival marks are mobile. They need to be in the neutral position. So in the left hand, you can see I'm using the forceps to hold the incision very tightly. I'm tunneling through the sclera 2 millimeters and then diving down into the eye. And this allows me to have a much more precise positioning and placement of the needle through the sclera. I'm using micrograspers to grasp the apex of the U of the haptic. And once I grasp the apex of the U of the haptic, I'm able to dock the haptic onto the bevel of the needle, straighten it out, flatten it out, and then once it's straight, I'm able to slide it and advance it very easily into the needle. Once I do this, I disengage the needle from the syringe, and I use a hemostat to do this. You need to keep the needle as still as possible so it doesn't move around in the eye uncontrollably when you're disengaging the syringe from the needle. I'm using microforceps then to internalize the leading haptic into the angle. I'm using my right hand to hold the eye in the neutral position with forceps, and then I'm tunneling through the sclera 2 millimeters and then diving into the vitreous space and then rotating the needle in my view. Now I'm using micrograspers to thread the haptic into the needle, but I want to get a good grasp. And even though I'm grasping from far away, because I'm able to dock the haptic on the bevel of the needle, I'm able to flatten it out, turn it, and then slide it in very nicely. You want to pull the needle out in the direction it came from. You want to hold the haptic and secure it with the forceps and then cauterize the tip and make a small little bulb. As I pull out the needle on the other side, you want to make sure that the haptic is grasped with forceps. and then use cautery to create that bulb at the end. You can see the patient reacted a little bit to that heat. I pushed the haptic flush to the sclera, and you can see the bulbs are embedded into the sclera now. But I noticed that the lens is slightly decentered to the right here. I mean, it's not a major problem, but it is slightly decentered. It's bothering me a little bit, and I want to be able to reposition it. But because of the hemorrhage, this patient has pretty mobile conjunctiva. Even in the beginning of the case, I noticed that the conjunctiva was quite mobile. And so now I have hemorrhage to deal with, and I have this very mobile conjunctiva, and it's kind of getting in the way. I'm using these McPherson forceps, and I'm really having a hard time finding the haptic and then grasping the haptic. And so you can see I'm really having a lot of trouble. I'm using some irrigation to help me find the haptic. I finally do find the haptic with the help of the irrigation, but I'm having a hard time. And so this is a great pearl that I picked up just doing it on my own. I just took the needle that I used for haptic fixation, and I was able to get underneath the flange and then pull it up. It was just so easy using that needle to pull up the flange. Once I pull it up, I trim the tip and then cauterize it and create another bulb. And I reposition the haptic, embedding it into the sclera, and now it's in perfect centration now. And so using that needle, the same needle that I used for interscleral haptic fixation, I was able to get right underneath the flange, lift up the haptic very easily. And in fact, whenever you're trying to do an IOL exchange and removing a Yamane lens, when you're trying to actually pull up the flange, this is actually the best way to do it. You want to get a hypodermic needle, a very small needle like I did, get underneath the flange, you'll be able to pop up the haptic upward. So I'm doing my peripheral iridectomy using the vitrector. I have that separate setting where it has a high vacuum, kind of a mild aspiration, as well as a very low cut rate. This creates a very controlled environment where I'm able to control how much iris is actually cut. Once I perform the peripheral iridectomy, I'm just doing a vitrectomy anteriorly, mainly to remove the viscoelastic from the anterior chamber. And then now I'm placing the vitrector through the pars plana, through the trocar, and I'm doing a little bit more vitrectomy in the posterior segment as well. Getting back to pulling up the haptics with the Yamane technique, I use the needle. I think that's the best way, but alternatively, pull the haptic up from inside the eye. You can actually grab the haptic from underneath the iris and then pull it up, and it might pop it up. But again, this is a blind procedure. It makes it a little bit of a challenge to do it this way. Using the hypodermic needle, getting underneath the flange and popping it up was really the most efficient and elegant way to do that. And with these complicated cases, including vitrectomy, I like to always place sutures through the incision. I'm going to put a tendonylon suture ×2 here, and I'm just speeding this up just for time's sake. After the suture is cut, I go ahead and bury the knots. I'm going to pull the trocar out. As I pull it out, I like to massage the conjunctiva and the sclera with the Q-tip, and I just kind of massage it quite well in order to facilitate a self-sealing incision. And then I start hydrating my incisions, and I have my AC maintainer active when I pull the trocar out. Once I pull the AC maintainer out, I hydrate the rest of the incisions. I inject some subconjunctival lidocaine to help with anesthesia, and then some subconjunctival ANSEF. So as you can see, even though you do all the right things and try to follow the technique by the book, you can still have decentration, and it's fairly difficult to pull that flange up once you bury it into the sclera. And so using that 30 gauge needle, getting right underneath the flange, you can pop it up really easily, trim it, cauterize it, and push it back in. This is my tip on how to easily pop up the haptic once you bury the haptic tip into the sclera. So I hope this was helpful to you, and I thank you for your attention.